Thank you for inviting me to talk about ultrasound of the lung and pleura. My name is Dr Richard Beese. I am a consultant radiologist in the NHS in London and have been practicing with ultrasound for 20 years, initially running a department at King's College Hospital and now running an ultrasound department in a busy district general in really the front line NHS in London. And one of my great enthusiasms is ultrasound. I initially was a physician and I had a stethoscope, and then I moved into radiology and I had ultrasound. And ultrasound is certainly a very useful and versatile tool for the diagnosis of patients. So so what we've got to ask the question: what information does ultrasound give us? What is it? Well, really, it's really examination of the anatomy and pathology. And with a stethoscope, we listen to the anatomy and pathology, and with ultrasound, we visualize it. And it's an adjunct to other imaging modalities, such as the chest X-ray. The chest X-ray is a two-dimensional image of a three-dimensional structure of the chest, and is a silhouette of the anatomy and pathology. And ultrasound just adds another dimension to that. And I hope in this talk I'm going to give you an overview of that. So what can ultrasound add if we have a chest X-ray? Equally, a lot of the world's population have no access to X-rays, and ultrasound is now becoming very portable, handheld, and of high quality. And there are doctors around the world with no access to X-rays, just using ultrasound without the X-ray at all. So there are two settings: one where you have the chest X-ray available, and two where you don't have any other imaging other than ultrasound. But this presentation is going to be about how it can add to the chest X-ray in certain clinical scenarios. And then examining the chest with ultrasound, well, it's not dissimilar to the stethoscope. So we use a curvilinear probe, which is a low frequency probe. There's a depth of about 10 to 16 centimeters. And if we examine the chest anteriorly, then we're looking at the upper lobes of the lung anatomically. And underneath the transducer is the image that we will see. If we examine the lung in the axilla, as in here, we're looking at the middle lobes. And equally, if we look at the lung posterior, it's the lower lobes. It's exactly the same as the stethoscope, as we taught as the stethoscope. And there are ways of examining it, either intercostally or transcostally, and I will talk a little bit about that. So let's just start and let's get a flavour of ultrasound and how it's actually evolved very quickly in a very short period of time to be useful in this pandemic we have, COVID-19. So I'm just going to go through the principles of chest ultrasound and then try and highlight them with some clinical cases. So we're all in the middle of this pandemic, or well, we are, and hopefully in the UK we're coming to the end of it. But basically what we found is that ultrasound can be very helpful for the early diagnosis of COVID. When the chest X-ray is normal, then we can use ultrasound. And we initially found out about this from our colleagues in Italy, and they told us how to examine the chest with ultrasound. We go across the ribs, we use a curvilinear probe, as I mentioned before, and this is what normal lung looks like. These are the A lines, the reverberation. This is what you would get between the ribs. And if you have subpleural consolidation, which is typical of COVID, as you know, COVID is obviously, well, is a respiratory virus, is a coronavirus, and it generally affects the periphery of the lungs. It's generally bilateral. And because it's peripheral, it's up against the chest wall, it's possible to visualize with ultrasound. You get these lines, which are the B lines. And if you see this on ultrasound, if this is normal, and if we see this, we can say there's subpleural consolidation in the correct clinical context, which generally is a cough and a temperature. If we were trying to look at this lesion with ultrasound, we would fail because there's a lung between the lesion and the chest wall, and this is what we would get. But because it's generally peripheral, we can pick up early COVID, and it's been found to be more sensitive than chest X-ray alone. So chest X-ray plus ultrasound has a higher positive predictive value for lung COVID. And as we know, the temperature starts, and about day 4, you can get early lung changes. So very helpful when the swabs are negative, which sometimes they can be, just to pick up lung COVID. And as also, I've found it very useful, ultrasound in the supine chest on an intensive care unit, where you've got the patient's supine. I'm going to go through some radiology now, where you've lost the hemidiaphragm silhouette. So you've got this hazy, diffuse shadowing. You can still see the silhouette of the heart borders, but bilaterally. And what the chest physician or the ITU consultants or doctors want to know is this fluid or is it consolidation? And obviously on ITU, the patient's supine, ventilated, very prone to effusions, very prone to RDS, and difficult to examine clinically with a stethoscope and percussion, but ultrasound, you can visualize what is going on at these bases. So here we have, this is an example of the ribs, and this is an intercostal space, and we're using this intercostally, and we're looking at the base of the lungs, and we can differentiate between this is normal lung, and this is what normal lung looks like. Here is the liver, and we have a highly reflective line here, which is the pleura, and it's highly reflective because the rest of the lung contains air. Now, many years ago, when ultrasound was evolving, there was so much interest in the liver, biliary tree, and abdomen that they really thought that lung ultrasound was of no use whatsoever, because lung contains air, and air is highly reflective, and therefore no image could be seen. But what became quite apparent about 20 years ago, even probably longer than that, is that when lung is abnormal, it becomes replaced either with fluid or becomes solid. So this is a very good. So here we have no image because of air in normal lung. However, from this chest X-ray, this is what you can see. So this is the spleen here, and the lung has become solid. And what we have here, these branching bright areas, and these are air bronchograms in consolidation. We've lost the hemidiaphragm on the left, and we have consolidation. So ultrasound can differentiate between normal lung and consolidation. This chest X-ray could also represent fluid. So when the lung is abnormal, it's replaced by fluid, or pleura has fluid within it, and this is what the image that we get. Here we have the visceral organ, it's probably spleen again, and then we have this echo pore area, and this is what fluid looks like. It's highly transmissible. Again, there's no image because sound waves are transmitted through as opposed to this area, which is soft tissue. So there's no image here because it's highly reflected, and there's no real image. Well, there is an image of fluid, but there's no internal echoes because fluid transmits ultrasound waves, whereas this is spleen here. This is grey because it transmits and reflects and produces this grey echogenicity. We can also look at the chest wall. This is something I've been particularly interested in. Patients come to A&E and have had trauma. And they come to A&E because they want to know if they've got a rib fracture. And it is quite important to know if they've got a rib fracture. Is it bruising or rib fractures? And traditionally, we just do a chest X-ray if it's significant trauma to exclude any complications such as pneumothorax. But the patients want more than that. They want to know if the rib is fractured, because it makes a big difference. If it's soft tissue injury, it normally recovers within 2 weeks. And if it's bone injury, it takes 6 weeks. And you can also tell your employee that you need tell your employee that you've broken a rib, which is significantly takes longer and need more rest. The other point is that rib fractures in the elderly have got a 10% mortality. They're extremely painful, and they cause hypoventilation and secondary pneumonia. So they've got quite picking up rib fractures. So this is what, again, bone was thought to be of no value. Ultrasound was thought to be no value in ultrasounding bone because it's highly reflective. There's no image behind it. But when bone becomes abnormal, it's often replaced by soft tissue or fluid. And this is the cortex here. So here's a normal rib cortex, the diaphysis, and here's the cortex here, and there is a small loss of alignment. There's a fracture here. And the important thing is there's fluid. All fractures, all bone, when fractured, bleed. Bone is highly vascular, and this is a subperiosteal hematoma, and that's a rib fracture. There's often point tenderness, but it's good to know. I mean, diagnosis is absolutely key. Patients don't want to know probables. They want to know absolutes. It is or it isn't, in my experience. And ultrasound can give us that. It can turn differentials into... Let's look at some cases. A 50-year-old man presents with a left-sided pleural effusion. Here's the effusion. He's lost the silhouette of the left hemidiaphragm. He's got a new silhouette, which is an air soft tissue interface between the lung and the pathology, and there's a meniscus. Now, we've done an ultrasound, and the ultrasound, so this is, let's just take this as far as we can with the chest x-ray. So unilateral pleural effusion, it's either transudate or exudate, depending on protein content, but because it's unilateral, it's most likely to be an exudate. And the differential for an exudate is between infection and the tumour can be benign, malignant, primary or secondary. And we've done an ultrasound, and what we found is soft tissue mass within this effusion. So this has turned this from a differential between infection and tumour into a diagnosis of course, the tumour can be benign, malignant, primary or secondary, and it can be primary or secondary of the lung or the pleura. But again, ultrasound is just taking it one step further. You will not get the true diagnosis until you do a biopsy. And of course, the patient would need a staging CT, but in the ultrasound, trying to differentiate what if you. Let's look at this 70-year-old woman with a cough, and she's got a temperature. Let's go through the soft tissue interface. It's soft tissue, and the right heart border. She's got a cough with a temperature. We've done an ultrasound, and we're not seeing fluid there. What we're seeing is solid lung. The air bronchograms, and this is consolidated pneumonia. So this chest x-ray, the differential for this is possibly effusion or consolidation. And if it's an effusion, it's infection or malignancy or tumor. And we've actually just converted this into the correct diagnosis of infection, and most likely to be bacterial. Now we see the branching structures here. This is air within the bronchi. So we're seeing the same anatomy and pathologist on a different imaging modality. If you had your stethoscope here, you'd hear bronchial breathing, transmission of large airways. But what we're actually seeing the air bronchograms here. And if there was collapse, you would not see any air bronchograms. So we can differentiate between consolidation and collapse on the ultrasound of the chest. And if there was a mass within this consolidation, we would also see that. So ultrasound is extremely helpful in cases like this. Here's a 40-year-old man. He's unwell, weight loss with a swinging temperature, and he's got this opacification in his right hemithorax. There's a straight line here. You've lost the laterality silhouette sign of the hemidiaphragm on the right. This is almost certainly a pleural collection and possibly an empyema. We do an ultrasound. So a pleural collection, it's unilateral, most likely to be an exudate, high in protein content, most likely to be infection. And then we've done an ultrasound, and there is fluid here, and there's also lots of proteinaceous loculi, indicating that it's high protein and most likely due to infection and empyema. Equally, now we have the imaging. What we could do is introduce a needle and aspirate for diagnostics, or we can introduce a needle, then a wire, then a tube, and drain this. And I've done this several times on ITU in particular, where patients have got collections, and we just use the ultrasound, one, to diagnose it, and two, to intervene and drain it. So here's a 60-year-old lady, woman, with increasing breathlessness, and this chest x-ray. And here's the chest X-ray. There's a large rounded soft tissue opacity in the left hemithorax. We can't see the hemidiaphragm on the left. We really can't see the heartboard, but it's got a very acute angle subtended with a pleura. So I don't think it's a pleural collection. I think it's actually a mass. So it's a large mass. So let's see how far we can take this on the chest X-ray. If it's a mass, well, it could be within the pleura or within the lung, and it could be either benign or malignant. And if it's malignant, it's either primary or secondary. Also, you could postulate that it could be a collection. This angle is against that, but it could be a collection of fluid. So we do an ultrasound, and we see it's a soft tissue mass. It's not a collection of fluids. So that's very helpful. We think it's a mass. It's either benign or malignant, and we can use ultrasound to do a biopsy. And that's extremely helpful. And again, it would have a staging CT. So here's a patient, a 70-year-old with a road traffic accident, seatbelt trauma, pain in the sternum. Now, sternal fractures can be non-displaced and not visible on the X-ray. Ultrasound can be helpful because here we have the cortex, and there's a disruption in the cortex and some fluid, and this is showing you the sternal fracture. Again, you don't want to miss these. They're extremely painful, but the X-ray can be misleading as they're often non-displaced, but the ultrasound can increase sensitivity. This is a recent case we had in our hospital of a young doctor from Egypt who had a cyst in his chest, which really confounded the chest physicians. They started draining it, and we did an ultrasound, and actually it was seen to have lots of these multiple peripheral cysts and central cysts, and these are daughter cysts, and this is hydatid disease. Now, in the UK, this is quite rare, and really it did confound us as to what this was. But once we did the ultrasound, we could quite clearly see that this was hydatid disease. And instead of it being drained, he was sent to the Tropical Medicine Hospital in London. So again, this ultrasound, or this further imaging, just changed the diagnosis. It changed the game. It changed the direction in which this patient was going from this trying to be drained to actually being sent for therapy at the specialist centre in London. So here we have a 52-year-old man with type 2 diabetes, cough and a temperature. And the chest X-ray is normal, but an ultrasound has shown that there is the B lines here. So here's the pleura, these are B lines, this is subpleural consolidation. In the presence of cough and a temperature in this climate, this has to be COVID, this is COVID until proven otherwise. Equally, I'm going to talk about this in the next talk. Patients with a normal chest X-ray and chest pain, ultrasound can be helpful. You can examine the heart with ultrasound, doing an echo, and we can look for right heart dilatation, thinking about pulmonary emboli. We can look around the heart to see if there's a pericardial effusion, and we can also assess the LV function very simply with ultrasound, giving an awful lot more information. Also, in the breathless patient, the chest X-ray can be extremely helpful with heart size and small pleural effusions and curly B lines, but so can the ultrasound, because it can also demonstrate the small pleural effusions. It'll demonstrate the interstitial patterns clearly. You can measure the JVP with ultrasound. You can measure the dilatation of the IVC and in patients with heart failure. Also, again, with patients with suspected pulmonary emboli, if the heart is normal, there's no right heart dilatation. If you're in A&E with ultrasound, you can examine the common femoral veins bilaterally and pick up deep vein thromboses. 70% of pulmonary emboli will have demonstrable deep vein thrombosis on ultrasound. So ultrasound is an extremely helpful tool. It doesn't replace clinical, it doesn't replace a chest X-ray. It just adds to the whole picture and actually can help with diagnosis. It's an extremely versatile tool. So in conclusion, ultrasound plus chest X-ray is certainly more useful than chest X-ray alone. Ultrasound is a versatile tool to demonstrate pathology, as I've just described. And ultrasound can turn differential diagnosis into firm diagnosis. What I went from when I was using a stethoscope to ultrasound is that I could say to patients, your abdomen is normal, the liver is normal. I couldn't do that with a stethoscope. And that's not being clever, that is because ultrasound demonstrates the anatomy and can give you absolute diagnosis with a very high negative predictive value. So let's just briefly go through what I've already spoken about the technique, curvilinear probe in the axilla, looking for the middle lobes and lingula. That's what that examines. Examining posteriorly on the chest is looking at the lower lobes, and examining anteriorly is looking at the upper lobes. And you can either do it intercostally, which is my preferred method, or you do it transcostally, i.e. across the ribs. And it's been extremely useful in this pandemic, COVID-19, for picking up early lung COVID changes. We don't use CT for diagnosis. We use ultrasound and chest X-ray in clinical, and we use CT for complications. And extremely useful for the chest X-ray on ITU. And we talked about what we can see at the bases. Again, normal lung here, consolidation and fluid. I hope you've got this picture in your mind, what a pleural effusion looks like. And then we've talked about chest trauma, rib fractures, and we talked about effusions and masses. We've talked about consolidation. We've talked about collections, unilateral exudatives. This is infection, empyema. We've talked about, again, masses, or is it a collection? Well, ultrasound will tell you it's cystic or solid. This is solid. It's a mass. Is it benign or malignant, primary or secondary? Well, the only way you're going to be absolutely certain is with a biopsy. And again, ultrasound can help you with the biopsy because it can sample it using ultrasound guidance. We do a lot of peripheral lung biopsies using ultrasound. And then we talked about sternal trauma and bone trauma. And then we talked about unusual cases. Certainly in the UK, this is extremely unusual, high dated of the chest, and how ultrasound can just take it. Is this a mass? Is it a cyst? Well, actually, it's high dated cyst. Thank you. And I look forward to our next talk and medical chest problems. Thank you very much.